Did you notice? How's it in the back? Is it okay? Good. The wings, good over there? Left field? Right field? Okay? Okay, good. All right, good morning. Okay, so as I mentioned in the last lecture, at the beginning of each lecture for the rest of the course, I'm going to try to introduce something that's tied to the prior part of the course that'll help even strengthen your understanding of prior parts of the course. And then depending on how the course goes, I think the last couple or 3 lectures, if I get this timed right, we'll probably have 10 to 15 minutes at the end of each lecture that we can have a general discussion of anything you want to discuss. It's like a final exam review. You can ask any question about anything from day one till the end of the class. So we'll see how that goes. So the first thing I want to do today is when I was fumbling around looking for this slide, I don't know how it got deleted. I just wanted to put it in here. This is this monkey study. Instead of being actively interested in their surroundings and curiously prying into all that came within the field of observation, they remained apathetic or dozed off to sleep, responding only to the sensations of the moment, stimulus bound, and they had lost the faculty of attentive and intelligent observation. That's the frontal lesion macaque monkey, which is used extensively in cognitive research. And we've already gone through this gentleman, and you've seen his movie, and you can see that he was locked in the moment with frontal release signs and abullic and under-aroused. It looks just like the frontal monkey. So I just wanted to put that in there because somehow it disappeared from my last talk. So, oh, wait. I know I'm missing something here. This. I tell you, the connector people are making a lot of money. Okay, good. That should work. Okay, so I just want to conclude on the frontal lobe slide. I did input, right? What? No. Yeah. So you've seen this evolution of the frontal lobe, and I decided to do an important study, which is the frontal lobe very important for intelligent behavior. Do a really important study comparing the size of the frontal lobe between Berkeley graduates and Stanford graduates. So the Berkeley graduates had a pretty nice looking frontal lobe. And then I noticed something odd after I analyzed the data from the Stanford graduates. There was a line here somewhere between a gorilla and an orangutan. And I refer to this as the big frontal lobe game. And guess who fits in there? It's just the facts, right? Now, just to make this even funny, I put this slide together really for fundraising because the alumni love this. They go crazy. They write checks. That's what you do. That's what you do it for. But I was giving some talk where there were a lot of Berkeley and a lot of Stanford people, and the moderator was a traumatic brain injury symposium, 300 people. And I gave this talk, and I finished with this at the end. And the guy who was running the symposium, you can't make this up, was a faculty member from USC. And I put this slide up, and he looks at it and he said, "Is that the same size as USC's frontal lobes?" I can't go there. All right. Anyway, you can use that if you're fundraising. Please feel free to use that slide. All right. So I wanted to just go back into epilepsy a little bit. That will be our little segue before we get into emotion. And just this is a really cool old picture in an operating room with some of the major people that we've talked about in the same operating room. So here's the great, brilliant Wilder Penfield, who, of course, discovered the homunculus and a lot of things about language organization from intracranial recording. Here's the brilliant Brenda Milner right here, who is still going to her office at McGill every day at the age of 95, which is quite a feat. I don't know where I'll be in 95, probably below floor level. But so she's our Scoville and Milner, the famous case where the bilateral hippocampus was removed. And in fact, this is even the gentleman who unfortunately had the surgery and forever was unable to learn new information. Anterograde amnesia that we've discussed extensively. In his case, it was due to bilateral hippocampal bilateral hippocampal resection, leaving him with profoundly amnestic, with a profound inability to learn new information. Now, one more thing before we get into emotion. I wanted to present this case to you, and I want to see what you think of the case. This is a gentleman who's 25 years old. He's been having drug-resistant complex partial seizures since the age of 6, multiple seizures per week. He's been evaluated at other places before. His seizures are classic, right, for complex partial seizures. Behavioral arrest, he stops, he does a lip smacking, and he does automatisms. Sometimes he rubs his hands, sometimes he moves his legs. The seizure lasts for 15, 30, 45 seconds, and then he's kind of postictal. And they have never been able to control this gentleman. Now, the first question is, anybody here want to be a neuroradiologist? Anybody want to be a neurosurgeon? Do you see anything wrong with his MRI scan? Can you read his MRI scan? What do you think? Anything? Because it was read as normal by 2 outside places over the years, and it's not normal. Do you see anything abnormal? It's hard to pick it up. Take a good look. You can see the temporal lobes. You can see, the temporal lobes, and you see the ventricles and the frontal temporal, anterior temporal, hippocampus. You're worried about something in the amygdala, maybe as a cause of his seizures or his hippocampus, very common source. So don't feel bad. Does anybody see anything abnormal on here? Go ahead, speak. You can speak. Go ahead. Take the pointer. Go for it. Be a surgeon. See one, do one, teach one. What? No, it's not here. Okay, you know what? You're actually in the right area. That's his brainstem, and that's his vessels. Did you have any? You want to take a shot? Where? Give it to her. It's the bottom one. Take a shot. Yeah, the bottom is the pointer. That's his amygdala. That's amygdala running into his hippocampus. That's actually okay. And the scan was read as, we'll get back to the scan in a minute. Let me show you the gentleman. I want you to really pay attention because this was missed for 19 years, the onset of a seizure. And he came into UC Irvine just a little bit ago. My friend Jack Lynn, who runs the program, correctly diagnosed him. So let's look at this gentleman's seizure pattern. Watch carefully what he does. At the beginning of the seizure, whoops. Now he's lip smacking, now he's having automatisms. What did he do right at the beginning of the seizure? Did anybody notice? He smiled. What else did he do? He laughed. Okay? That was missed for 19 years. Anytime you see a seizure that starts with giggling or forced laughing, there's only one thing that does it, and that is a hypothalamic hamartoma, which is exactly what he has. And they're called gelastic or laughing seizures. And what happens is you're irritating your hypothalamus, and you have these massive projections from your hypothalamus into your amygdala. Now he's into the temporal lobe, and now he's showing the classic complex partial seizures that you'd see in temporal lobe, amygdala, hippocampal sources. So this is gelastic seizures. This particular gentleman, Jack's team put a stereotactic laser into this, burned it, guy doesn't seize anymore. Pretty interesting. Gelastic seizure. You say, oh, they're rare. Okay, I want to just reemphasize to everybody who might ever be doing anything with a human being, it's not rare if you have it. Then it's 100%. So that's your job is to figure out what's going on in an individual patient. Obviously, you take into account epidemiology and probability and statistics, but at some point, you kick it out the door and you figure out what's going on with that individual human being. So gelastic seizure is cured. Very nice. Thank you, Jack. And the patient's quite happy. Okay, so let's talk about the limbic system, because there's a lot of people here, I'm sure, interested in emotional regulation. It's the emotional social brain. It's got a long history. It's slowly evolved over time. It's still at the forefront, I think, of interest. I think in some ways it's even more important than our intellectual part of our brain, our lateral cortical stuff, because if you don't have good social, emotional performance, usually everything else doesn't work too well in your life. And, of course, it's implicated in untold numbers of developmental and neurological disorders. So the limbic lobe was actually defined by our old friend, Paul Broca, who we'll talk about in a week or so when we get deeper into aphasia. And he didn't really make any inferences about it being associated with anything. He just said there's kind of a limbus. There's a thing circulating, going around the corpus callosum, and he just called it the limbic lobe. He had no idea what it did. He just called it the limbic lobe. So it's kept that name forever. So you can thank Broca for the name. The important advance occurred in 1937, where two independent papers appeared in what was then the number one journal, actually, in neuroscience, the Archives of Neurology and Psychiatry. Interestingly, when you look at the history of scientific publication, it's now almost a throwaway journal. They send it to you for free. It has a lot of ads. But at that point, it was like Nature, Science, Neuron, etc. It was the big time. Pabst proposed a mechanism of emotion. And let's go through this, because it's a really interesting story. He was a neurologist and a comparative neuroanatomist, so he knew neurological disorders. He knew brain tumors. He knew stroke. He saw all these kinds of things, and he also knew how the brain was organized anatomically. He based his theory on neuroanatomy and postmortem neuropathology and on clinical observation of two basic clinical groups. One were tumors in the cingulate region, which we'll get into a little bit later in the course. And the tumors in the cingulate region, with its massive frontal projections, look just like the frontal patients. They are apathetic with decreased motivation. He said, okay, depression is apathetic and decreased motivation. This must be part of the neural system for emotional regulation. So that was his point one. Then the second point was, at that time, rabies was endemic, right? People, there were lots of rabid animals. Animals were not getting vaccinated. And if you got bit, you were in trouble. Because if you were bit by a rabid animal, then you died, basically. How fast you died depended on where you were bitten. If you were bitten in the leg, the virus travels up to small sensory fibers, gets to your spinal cord, and then travels up to your brain. It might take 2 weeks before you get symptomatic. If you get bit in the face, you're going to go right in your fifth nerve and be in your brain in maybe 3 days or 4 days. So the onset of symptoms depended on where you were bitten. So the onset could take anywhere from 2 to 4 or 5 weeks. Now, the way the syndrome starts is it looks just like a bad flu. Has anybody had this? Fever, headache, you feel bad, and you got a sore throat. Who's had this? Yeah, right, more than half the class, right? But with rabies, it starts like this, so you don't know if the patient is just, needs to go to the Tang Center or if they've got rabies. Because once it goes to the next stage, the patients become restless, overactive, talk like crazy. They're really freaked out. I've only seen one case, and they're really scared. They're agitated. They become almost maniacal. They're jumping out of bed, screaming. It's a horrible thing to see. They start getting throat spasms because from the disease, and they can't even take down fluids. Mercifully, at that point, they develop seizures and they die. So if you look at this course of this patient, there's a couple things in here that would suggest what other psychiatric disease besides depression. What are some of the features of this patient? What would you categorize it as a psychiatric disorder? Anybody want to take a shot? Nobody? Please. Yeah, go ahead. Mania, absolutely. What were you going to think? Were you thinking the same? Yeah, it could be schizophrenia, it could be bipolar with a manic burst. Exactly, right? Because you're both exactly right. Because, you look at mania, increased talking, increased agitation, maniacal, etc., those features. And he said, okay, if I can figure out where rabies affects the brain, now I've got not just depression, I've got psychosis. And I've got a lot of the infrastructure of what is in the basis of major psychiatric disorder. So that was the logic. And it was a pretty solid logic in many ways. And so This is his proposal, which we'll get into in some detail. He basically decided that based on his findings of where he proposed this system, which included the cingulate, which we've just talked about because of tumors, and then he included the hippocampus. And why did he include the hippocampus? He included the hippocampus because it turned out when someone died from rabies, and the doctors wanted to diagnose that they died from rabies, they take a biopsy from the hippocampus. So it was basically a sampling error. If you could sample pretty much anywhere in the brain of someone with rabies, and you're going to find evidence of rabies infection. But because they only sampled one area, they made the mistake, or he made the mistake, of a sampling error. They only sampled the hippocampus. The neuropathologist sampled the hippocampus and the cerebellum to make the diagnosis of rabies. They have what are called Negri bodies, and you can see in the cells. He knew the cerebellum couldn't be involved in emotion. It just is involved, as we've seen, in your balance control and fine motor movements and all the things we talked about in the class. So he said, you know what? That means the two things the two areas that must be your basis of emotion are the hippocampus and the cingulate. But rabies is more extensive, so this was a mistake. It was a fundamental error, but the whole world believed it. And more importantly, as you know, selective hippocampal lesions do not produce dramatic behavioral changes. You don't see mania, you don't see schizophrenia, you don't see depression. You see anterograde amnesia. So the whole thing didn't really match. But it got a lot of press because it was a nice theory. Now, if you look at all the areas he localized, which are two, he said the hippocampus and the cingulate. If we fast forward now to 2018, the only area that you really can ascribe to being connected to emotional regulation is the cingulate. And in fact, sub-areas of the cingulate, particularly if this is the front of the corpus callosum, this area right here below the front part of the corpus callosum is heavily involved in emotional regulation. In fact, it's a target of treatment for depression. There's an area right here called this is the genu of the corpus callosum. There's an area right here called area 25, which has been a target for stimulation in trying to treat people with refractory depression. So that was correct. Right? The cingulate was definitely in play. And we talked about this a little bit before, where you could have a course on cingulate function. It's an extremely interesting part of the brain. It's heavily bidirectionally connected to both the lateral and the orbital frontal cortex. There's parts that are more connected to the lateral frontal cortex, the so-called cognitive part of the cingulate, and parts anterior and in this area, area 25, that are more connected to limbic areas, which we'll get into the real emotional areas, which include the amygdala and also include the orbital frontal cortex. So very, very interesting story. Cingulate correct, everything else that he proposed wrong. It's still cited as the key paper because it kind of, at least, I think what it did, it made people start thinking that just like we knew from aphasia literature and Broca that there was an organization in your brain for language, it was exciting because maybe there's an organization for all these wonderful social, emotional things that we do. So let's see what the true story is. In the same year, in the same journal, in the Archives of Neurology and Psychology, Kluver and Busey, who were at Northwestern University, did a very interesting series of experiments in monkeys, which I kept a couple of my old. When I started this course in 2000, there was really no PowerPoint, and I had overheads. So I decided I kept a few of my old overheads. This is my very sad rendition of a monkey brain with Kluver and Busey lopping off the anterior temporal lobe. You like this? Are you embarrassed? You're I do. Yeah, I have all the transfers. You never get rid of anything if you're a collector. I have a projector. I have everything. Do you want me to bring you the rest of the class with overheads? It'd be kind of fun. Or you could replace this with a slide that looks real. That's the other option. But anyway, this is, it works. So they lopped off both anterior temporal lobes in the monkey. And lo and behold, what they found is a really interesting set of behaviors in the animal. First, the animals didn't have a fear response. And if you've ever seen these movies, if you bring with monkeys, if you approach a cage with a rubber snake, a monkey freaks out and jumps to the back of the cage. If you do the same experiment in a monkey that has no amygdala, they don't jump back and they might even approach the snake. They've lost their fear response. Okay? In addition, they lose their social position. Whoops. They lose their social position. So in the monkey hierarchy, if they were up here, they're going to drop in the hierarchy. They also, in monkeys, are hypersexual. They show increased mounting behavior, which is, in general, sexually undifferentiated. Now, there are other parts of their syndrome which are reported by Kluver and Busey, but now as we know more about the brain, they're not really emotional symptoms. And that's because the resections went a little farther back in the temporal lobe, starting to get what we'll see later in the course. The ventral stream of your temporal lobe allows you to do perception and extract objects and understand what's in the world. And they took part of that out. And the animals had some degree of what is referred to as psychic blindness. They were having trouble recognizing things in space that they were presented with. And what they would often do, like monkeys do, to figure out what it is, they'd pick it up and put it in their mouth and explore it and see, oh, that's an apple, that's a banana. But those are really not part of the social emotional brain. As you'll see later, those are part of visual perception. These are the key findings right here from Kluver and Busey in 1937. MacLean, from perusing all this literature, someone finally pieced together that Paps's theory about the neurobiology of emotion should at least add the amygdala. So in 1952, MacLean actually published another paper where he took basically Paps's paper and added the amygdala. They still had the hippocampus in, but of course we didn't have Scoville and Milner yet, because that was not until 1956. So this was correct, and this was correct. What happened next? Okay. Honing down on the monkey amygdala literature, this is the best paper out there. This is a paper by my colleague David Amaral at UC Davis, who runs the Mind Center, which is predominantly focused on developmental disorders in kids, autism spectrum, and various other problems with children. And he did a really interesting study because, remember, Kluver and Busey just cut out the anterior temporal lobe. It got rid of the amygdala, but it also got rid of all the cortex, and it also got rid of any fibers going to and fro from other areas of the brain. So it's kind of not a clean lesion. What Amaral did is use ibotenic acid. Now, what's ibotenic acid? Remember when we talked about amnesia from glutamate release? Remember CA3, you get a cardiac arrest, you release glutamate, you kill your CA1 cells, and you end up with an anterograde amnesia. Glutamate is a very powerful excitatory drug. Ibotenic acid is not in your brain naturally, but it is, again, an extremely powerful excitatory toxin. So you put it in neurons. It doesn't affect any of the white matter pathways going back and forth at all, but it kills all the neurons. So this is a beautiful, selective, very selective amygdala damage. And what he showed, this is the true syndrome, that they might even have increased social contact, maybe not of good quality, decreased fear response, poor evaluation of the safety, which goes with the decreased fear response. Bizarrely, not bizarrely, but if you have a Kluver-Busey syndrome, it turns out other monkeys find you more attractive, which is an interesting thing that you could talk about for ages. Typical species, they have typical facial expressions, grooming, and play behavior. So really, again, this fear response and something off with their social interaction. So his conclusion is ibotenic acid selectively damaging the amygdala, sparing the temporal pole and fibers, basically has selective effects on social cognition and emotion. This is the key paper. I mean, this is what the Kluver-Busey amygdala syndrome is. So what other support do we have for the amygdala in this story? There's a lot of imaging data. This is stuff actually There's a gentleman, a scientist, Paul Ekman, who came up with this facial action coding, and it's used extensively at Berkeley. Some of you may work with Bob Levinson, and if you show people in a scanner, let's say it could be a PET scan, it could be an fMRI scan, and I show them neutral faces, or for instance, scared faces, etc., and I do a comparison to the scared minus the neutral, what you find, angry minus neutral, you find in the amygdala, you find activation, 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 activation. And if you notice, it's not just fear. All emotions activate your amygdala. It is true that a fearful stimulus is the easiest thing to get a big response. And you know, fear is an important thing in the field, right? You need to be able to get away from danger. But so you can kind of think of the amygdala as the sensory cortex, if you will, for your emotional processing. Just like your visual cortex extracts visual input and your auditory extracts sound information, your amygdala extracts from the scene, from the facial expression, whether it's fear, whether it's neutral, whether it's sad, etc. So it's acquiring this very important information, and it's acquiring it very rapidly in under 100 milliseconds. So it's there for the rest of your brain to now use. What should I do if someone's smiling at me? Maybe I should approach. What should I do if someone looks angry? Maybe I should withdraw, etc. So, and you want to do these things really pretty quickly. So, yeah, please. Let me see if I do this. Did it work? Yeah. What?
The thing on his face, what is that? Is that important to the...
That? This here?
Yeah.
Probably my granddaughter put it on my slides. I don't know. It's just a piece of junk on the slide. When my daughter was 3 years old, so that was 35 years ago, I gave a talk in Mexico City. There wasn't PowerPoint, and you weren't, you guys were around. Most of you weren't around. And you had to bring your slides on your own carousel. And I used to really care about my slides. I put them in glass. And you have to take your carousel because you never know. They might not have a carousel that can take glass slides. It may be too small. So I get down there, put the carousel in, put the first slide up, bing. She's taken all my slides out and colored them with magic markers. It was great. It was really, what are you going to do? So I don't know what that is, but I have no clue. It's totally irrelevant. The amygdala extracting emotional information from the world. Okay, and we've gone through this, earlier in the class when we talked about traumatic brain injury, and you can see in terms of, real-world problems, forget about developmental disorders, just basically head trauma. Look at the areas that get whacked, right? It's your sphenoid ridge gets your amygdala, your cribriform plate gets your orbitofrontal cortex, and this has been known forever, and these patients all turn out to have problems with social, emotional regulation. So now we've talked about the cingulate, we've talked about the amygdala. Let's see if we can bring now the orbitofrontal cortex into the story so we can complete the loop on understanding this critical circuitry. So here is, before we get to orbitofrontal cortex, what are some, trauma can produce a Kluver-Bucy syndrome. We've talked about it. We've also talked about, and here's trauma with a terrible hemorrhagic necrosis. This is obviously a fatal case. I want to just take a look at this cortex here. You see those little flecks of dark? Those are actually little contusions. And those probably are not going to be picked up even on the most high-field MRI you can find. And that's, but just this. Let's say the person didn't have anything else, no other damage from the trauma, and just a couple little flecks of blood right there that you don't see anything on the CT scan and the ER. Then they start seizing. You don't see anything on the MR scan. Basically, they've got a small below the resolution of the MRI scan damage in their cortex. Remember when we talked about what's the very common cause of epilepsy in your age group? Trauma. And that's all you would need to end up, that's all you would need to end up with an epileptic brain. So here's an MRI scan of a patient who survived. You can see the severe damage in the temporal lobes. Same patient. You can see the damage goes up to right and it encroaches on, wipes out the amygdala on this side and partially on this side. Then we talked about herpes simplex encephalitis, right? Type 1. This is a patient who survived a long time, and you can see a chewed up temporal lobe. Here's another patient with massive destruction. This is your limbic system. Your temporal lobes are out, and your cingulate is out. If you watch the cortex, normal, 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 and all of a sudden, boom, you've lost your cingulate. And then finally, another common cause of social emotional dysregulation is what we've talked about, tauopathies and frontotemporal dementia. 5 or 6 or 7% of all the dementing disorders out there. And you can see this, but this is an advanced case, of course. They start quite early. You would at the onset, usually you might not even see any structural damage that you could pick up yet. But you can see in this advanced case, the severe look at the normal-sized gyri and sulci in the back of the brain, severe knife-like atrophy here, and you can see how bad the frontal lobe is atrophied. So there's lots of things that can cause this kind of acquired misery, in addition to developmental disorders, which often have no clear biological marker that you can discern on an imaging study. So the human Kluver-Bucy syndrome is a tiny bit different than the monkey, because we're a little bit different than monkeys. There is a prominent affective disturbance. When you see these patients, you know right away they're odd. There's some, you just can tell they're off a little bit. They're a 16th of a note off in terms of interaction. They virtually always lose their social position. If they had anything, they were a director in a company, they're no longer director in the company. They can't handle that level of social interaction. They also have hypersexuality. They're constantly thinking about sex and often trying to approach people or make comments, but they really have an overall much decreased level of social context. Humans are able to where the monkeys have increased mouthing, that's not what happens. These patients really don't have any increase, and actually they have a decreased amount of sexual contact. But they have a very active internal sexual mindset. The secondary symptoms, just like we discussed before, depending on how much of the hippocampus is damaged, they obviously can have anterograde amnesia. And again, depending on how much of the inferior part of the temporal lobe is damaged, they can get visual perceptual problems. Right? So, but the real part that's linked to social emotional are these core symptoms, basically. The human Kluver-Bucy syndrome. Now, a little bit about the amygdala and memory. We know the hippocampus is key. Does the amygdala do anything? Well, of course it does, because everybody in this room knows if something emotional has happened in your life that is at all salient, you're going to remember it better than anything else that happened that week, that month, or that year. Can everybody agree to that, right? That's just the way we are organized as humans. And it turns out that that's what you find when you test patients. So here's this beautiful amygdala, and here's your hippocampus. They have massive interconnectivity between the amygdala and the anterior part of the hippocampus. So if I ask you to remember 100 words, and I have a delay of a couple hours, and then I have you regurgitate the 100 words, and this is the behavior, and of those 100 words, let's say 10 or 15 of them are emotional words. Or let's say it's pictures, and 10 or 15% of the pictures are emotional. And then I do a memory recall for anybody in this room. What you're going to get, you're going to recall this many neutral stimuli, this percent of the neutral stimuli, and you're going to show a disproportionate increase in memory for the emotional stimuli, right? So it's going to be, that's normal. If you take someone with amygdala damage, interestingly, the neutral stimuli, they remember just as well as you. So if you look here, the degree of memory for the neutral is equivalent, but they don't get the boost, the emotional boost. They've lost that emotional boost that will tell the brain, store this information, keep it around. And we've done quite a bit of work, and Colin's been involved in this, looking at, with intracranial recordings with electrodes in the amygdala and the hippocampus in humans, and there's a very elegant network of information transfer with the amygdala actually for emotional events actually driving the hippocampus. So we're beginning to tease out, some of the network for this in humans. So that's memory in the amygdala. If I show you, I put you in an fMRI scanner or a PET scanner, and I show you in an emotional versus a neutral movie, you're going to have increased amygdala activation, to, just like I showed you with the simple faces, you're going to show increased activation to the emotional stimuli. You'll see increased activity to threatening and effective stimuli in both fMRI and PET scans. The memory, this is really interesting, is the memory for these emotional events. How much you remember, let's say you watch a half-hour movie and there's 15 emotional events. The amount of activation you had to each emotional event in your amygdala is going to predict whether you remember the details of that emotional event. So these things are really pretty nicely, they're pretty tightly linked. So memory correlates with the degree of activation. Now, very interestingly, beta blockers, there's a lot of beta receptors in the amygdala. Beta blockers block the emotional boost that you get. They shut down your amygdala. And this is some very nice work done by Larry Cahill and James McGaw down at UC Irvine. And James McGaw is a fabulous scientist. He's a Berkeley PhD in psychology who's done a lot of very, very important seminal work. And I mentioned the Kids Journal the last time. We have a live review at Irvine at the end, and there's 3 faculty members presenting papers to a panel of kids 8 to 14. And he's 86 years old, and he's presenting a paper to the kids. And he's going to get interviewed live in front of an audience. So he's a good sport. Now, why is that beta blocker, why could it be important? Well, it turns out there's some studies now. If someone undergoes a severe traumatic thing, bad car accident, violent attack, whatever, and you're at risk for development of PTSD, there are actually some studies now showing if in the emergency room you put the person on a beta blocker, it suppresses their rumination and replay of the emotional events and may decrease the propensity for them to develop long-term PTSD. The studies are still in progress, and I wouldn't say it's absolute, but it's a very interesting connection between basic science and something that, yes, please.
When I think about beta blockers, it's supposed to reduce physiological.
Yes. No. It actually, no, I'm sorry, it's not the peripheral symptoms. It's actually blocking activity in the amygdala. They're beta receptors on amygdala neurons, and the beta blocker is actually shutting them down. So you're turning off your amygdala, basically, if you think of it that way. It's the same as if you'd put, you don't want to do ibotenic acid because the cells would be gone, but you're shutting off the amygdala transiently with the beta blocker. So very interesting basic science to clinical science in the emergency room. So in the lesions, impaired fear conditioning and perception, loss of social position and social reasoning, decreased memory for emotional events, and a kind of odd affective disturbance. They're just not, they're not right. The patients are not right. Okay, so now we've dispelled some of the ideas that Pabst proposed, although, it was great for him to propose a theory. We've decided that the cingulate is important. We've clearly added the amygdala. And now we'll go to the next level of the neural network for regulating emotion. And then we have to turn to another big white matter pathway that you can easily see with diffusion tensor imaging. Here's your amygdala sitting here, and there's massive connectivity between the amygdala and the orbital frontal cortex through this big bundle called the uncinate fasciculus, UNCINATE. It's huge, and it's really key because this is a big, fast highway to move information between these 2 key brain areas. If I put an electrical stimulator in the orbital frontal cortex and put an electrical jolt, I'll get a response in the amygdala in 10 to 15 milliseconds. I mean, these are really fast conducting. And I think we talked about this a little bit when we talked about pain. A lot of these really key pathways that are moving around information between big areas of the brain are really fast conducting. And what makes an axon fast conducting? One, how the diameter, the bigger the diameter, the better, and the more it's wrapped. So if it's fat in terms of its diameter, and it's wrapped nicely, it'll conduct quickly. And some of these fibers conduct at 50 meters per second. You can do the math on how quickly you can move information around. Okay? All right, so this is important. So how did we come up with the idea that the orbital frontal cortex would be so key for emotional and social regulation? We have to go back to the neuropsychological literature again. And these are what you see in orbital frontal patients right now. We have many, many patients with these kind of problems, and we've already gone through the potential etiologies. Emotional dysregulation, disturbed social behavior, poor decision-making, impulsivity, impaired goal-directed behavior. They just flip from idea to idea. Impaired theory of mind. Really, this is really important. You can't read people's inferences. Theory of mind develops when you're 3 or 4 years old. It means I can look at two people interacting, and I can tell they either are they're happy, they're neutral, or they want to kill each other. I can infer their mental state. These patients can't do that. That makes them susceptible to being manipulated by people, right? Because they can't tell what you're actually trying to, they can't get a good read on who you are and what your mental or guess what your mental state is. But they have normal fear conditioning. And interestingly, physiologically, where the lateral frontal patient, if I give them an orienting stimulus, they don't respond. They're just a bullet. They're suppressed. If I give an orienting stimulus, a shock, a weird sound, a weird visual fractal, the people in the room, everybody here, the first time you see it, it's this big, your brain response, then the second time it's this big, and by the 5th time it's this big. You habituate. I've seen it 5 times. If you do the same stimulus with a patient with orbital frontal damage, the first time it's this big, the second time it's this big, the third time it's this big. They don't habituate. So they've got an altered physiological system, and that makes them hyper-responsive to things in the environment that you would not pay attention to anymore, right? So these are kind of the overall general pattern of things you see in these patients. Now, there's a lot of data out there on the comparison between human and a monkey cortex, and this is man here, and we have our sub-areas, the medial part here and the lateral part, but you have the same areas in monkeys, and there's a whole wealth of research going on internationally and quite a bit at Berkeley, some in my lab. Joni Wallace has a really active lab, trying to understand exactly how the orbital frontal cortex is supporting all these very important social and decision-making processes. And it's really beyond the purview of this course, but I just wanted to let you know this is a very, very hot topic, because if you just think about it, it's salient to normal human behavior, and you pick your misery in terms of developmental disorders and neurological disorders. It's just an incredibly important part of the brain for us to understand. Now, one thing that I found interesting is when they do fossil hominids, and they've got, going back, and the size of the human brain and how it evolved, turns out that it looks like the part of the human brain over the last couple 100,000 years that evolved the most is the medial orbital frontal cortex. And if you think about it, that's what's happened over the last couple 100,000 years. We became more social, and we had to figure out how to interact in groups and how to be cooperative and how to do things that allowed us to make the whole much more valuable than the individual. The key thing about social behavior is really that one and one is not 2. You work together, 1 and 1 can be 3. Right, you can have you can just do more when you are cooperative. So this is very interesting. This area seems to be the biggest relative expansion of all the areas in your cortex. You'd think language. Language is probably number 2, but again, if you're stuck on an island, if you had to give up language or decision making, I'd give up language. You're going to survive. You're going to have in fact, there's some interesting studies where they lesion frontal cortex in monkeys and put them out in the free field of life, and they actually can't function anymore because they're impaired in all kinds of decision-making. So we're up to this point now. I think it's a pretty good natural break point, because when we start again on Monday, we're going to go into the classic case in detail. You're going to be world experts on Phineas Gage I know you've heard about him from a zillion people, but I've actually been at his blast site, and I've actually got the rods. So we're going to have a good time on Monday, and have a good weekend.